Hi and welcome everybody. A warm welcome to everyone on behalf of the Zero Suicide Australasia and Trans-Tasman Suicide Healthcare Alliance. My name is Matt Welch. I'm going to be your host for this exciting two-day forum. Before we start, I'd like us to acknowledge traditional custodians of country throughout Australia, their connections to land, sea and community. We pay tribute to Aboriginal and Torres Strait Islanders' unique values and the ancient and enduring cultures which deepen and enrich the life of our communities. We pay respect to elders past, present, and extend that respect to all Aboriginal and Torres Strait Islander peoples. I also like to say kia ora to our New Zealand brothers and sisters, and I would also like to respectfully acknowledge the iwi Māori, tangata whenua of Aotearoa. We acknowledge the individual and collective contributions of those with lived and living experience of mental health, crisis and suicide, their significant others, family, friends and carers on the journey with them. Each person's journey is unique and a valid contribution to our commitment to mental health, suicide prevention system reform. We will be exploring issues today that relate to suicide and which we will aim to do sensitively and respectfully. If this is potentially triggering for you, please reflect on whether today's session is right for you at this time. And please make sure that you reach out to your support network if you need to. So let's look at today's program. So we are lucky enough to have some fantastic leaders speaking today about the essential role that leadership plays in suicide prevention reform. Following each presentation, there is hopefully going to be time and an opportunity for everyone to ask some questions. So put your questions up during the presentation as well. We have moderators that try and help pull this information together. So this function, I believe, is on the right-hand side of your screens as we move forward. We don't have a chat function enabled at this time, and we will be taking some short breaks, which is built into the program. So please stay with us throughout the day. So without further ado, let's move on to our first presentations for today. I'd like to introduce to you Professor Nicholas Proctor and Sarah Davis Gilmore. They're going to focus on leading with lived experience. Sarah is a carer, lived experience worker at La Trobe Regional Health in Gippsland, Victoria. And Nicholas is the chair of mental health nursing and professional lead for nursing at the University of South Australia. So this opening presentation aims to provide us with a stark reminder on the purpose of why we need and how we can improve responses when people with suicidal behaviour present to our health services. So please welcome Sarah and Nick.
Hello everyone. I'm joining you today from the unceded lands of the Gunai-Kurnai peoples, and I would like to pay my respects to their elders past and present, and I extend that respect to any First Nations people joining this forum today. As mentioned, my name is Sarah, and I'm a family carer, lived experience worker at La Trobe Regional Health in Gippsland, Victoria. But I'm first and foremost a mother. A mum who has spent years navigating systems that often felt more like a maze than a source of support. I was trying to hold my family together and support my children through mental health challenges and suicidal distress, while also struggling to find common ground with the services we were relying on. One of the biggest challenges in suicide prevention and mental health care more broadly is that distress is still primarily viewed as a clinical risk to be managed rather than as a human experience to be understood. This framing can distort the focus of care, often pulling families and natural supports into a state of hypervigilance, where the goal becomes preventing perceived risks rather than truly supporting the person. Early in my daughter's healthcare journey, almost everything about her was viewed through the diagnostic lens of an eating disorder. While treatment focused on managing her behaviours, the wider picture remained out of focus. The relational and environmental context was deprioritised and sometimes missed altogether, as was the opportunity for trauma-informed care. Trauma-informed care is a buzzword these days, But there is a wide gap between being trauma aware and practicing in truly trauma-informed ways. Understanding the prevalence of trauma is only the first part. It's about practicing in ways that actively seek to avoid re-traumatization. People shouldn't have to disclose everything they've been through, especially when they don't yet feel safe, in order to receive trauma-informed care. It wasn't until 2 years into my daughter's healthcare journey that the focus finally shifted from what's wrong with her to what has happened to her. And that shift only came because she was courageous enough to break her silence. But by that stage, some aspects of her care had unintentionally echoed the disempowerment she'd experienced in the context of family violence. Instead of restoring agency and trust, parts of the system had mirrored the very dynamics that she needed to heal from. This is one of the perverse outcomes of a prevention mindset that is rooted in risk management. Treating distress and coping strategies as symptoms to be contained or controlled, rather than signals calling for social, relational, and structural responses, rather than fostering safety. This often results in further disconnection, invalidation, and disempowerment. These kinds of dynamics are not just theoretical. They play out in very real ways. For my daughter, our collective efforts I was a part of as a member of her care team, were necessary to support her medical safety, but the ways in which coercion, power, and a lack of attuned trauma-informed support were embedded in her care experience contributed to a deepening of her suicidal distress. There was little space or support to process the loss of her coping strategies or the distress they were helping her manage. Sadly, this kind of experience is not uncommon. Now, to be clear, this is not an argument against medical care or refeeding, both of which are essential elements of eating disorder care. But it is a plea for healthcare leaders to recognise that when we fail to see the whole person, and trauma-informed practice is not prioritised, well-intentioned interventions can result in iatrogenic harm. And this has consequences for the individual and their family and natural supports. For people who've previously experienced invalidation and harm in care settings, returning to an emergency department can feel unbearable. It takes tremendous courage to walk back through those doors because you know the risk. You might face similar responses again. Invalidation and stigma are huge barriers to care, but you go anyway, because in that moment of suicidal distress, there aren't any other accessible options. If the response isn't coercive, it might instead involve exclusion or denial of support and be shaped by prejudice. And what follows can be just as devastating. When someone leaves hospital without collaborative safety planning, meaningful follow-up, or support to navigate care transitions, the days that follow can feel endless. For many, these gaps are not only administrative, they leave people and families adrift at their most vulnerable. For us, that gap became a void. After being discharged, after she tried to take her life, my daughter withdrew further. It was an isolating and frightening time for all of us. As her mum, I knew she needed support, but in the end, she chose not to engage with services, not because she didn't want help, but because she'd lost hope that the system could actually help her. By then, she'd internalized the sense that services weren't really seeing or hearing her, and we had no clear path forward. Now, thankfully, that's not where our story ends. Change is happening. It's slow and inconsistent, but there are moments that show what compassionate, trauma-informed, person-centered care can look like and why it matters. Last year, our experience of the system was different. Safety planning happened, and it wasn't a tick box exercise. It was collaborative and thoughtful. Medical and mental health staff worked collaboratively with us to respond not only to her immediate needs, but to develop a structured plan moving forward. And most importantly, every member of the ED's multidisciplinary team was compassionate, consistent, and trauma-informed. They listened, they validated, they used sensitive, respectful language, and they treated both my daughter and myself as people whose experiences mattered. It sounds simple, but the impact was profound, and it went a long way towards restoring trust. Whether someone receives validating trauma-informed care should not be dependent on which clinician, nurse, or doctor they happen to see. If we're serious about zero suicide, then experiences like this need to become the norm. The biggest change for us, though, came after discharge. For the first time, my daughter had access to post-discharge peer support, something that hadn't been previously available due to the absence of youth peer specialists in our area. But now as an adult, she was eligible. So she received emotional and practical support from someone with lived experience of mental health challenges, service use, and recovery. I'll never forget the day when my daughter first met her peer worker. When she got home, there was something different in her voice, a lightness I hadn't heard in a very, very long time. She said, "I've never spoken to someone who's been through similar things to me and knows what that's like. She really gets it." In that moment, and over the coming weeks, I witnessed the quiet power of peer connection. Peer connection transforms lives because it reignites hope through shared experience, mutual understanding, and a sense of not being alone in the struggle. She felt seen, understood, not by someone doing to her or for her, but by standing with her, holding space and supporting her to find her own voice. Peer support offered more than emotional connection. It eased stress, clarified her support options, and helped her to navigate the system and services. One of the most empowering things her peer worker did was support her to create an advanced statement of preferences, helping to ensure that if she engages with acute services again, her values and treatment preferences are considered, including if under compulsory treatment. People don't just need treatment, they need trust, safety, and connection. Recovery is built through human relationships. Support for people experiencing suicidality must be relational, not just procedural. Genuine person-centered care requires us to move beyond models of risk containment. We must create structures that respect autonomy, foster connection, and embed dignity into every part of the system. This time round, I was also fortunate to access family carer peer support, and it gave me the space to reflect on how my daughter's distress was shaped by and connected to experiences that had impacted our whole family. Families carry personal and collective histories that affect each of us in different ways. Having the space to process that and to think about my own needs while continuing to show up as a mum and as a lived and living experience worker made a real difference. I continue to live my experiences as I work in the system. They didn't stop just because I moved into a designated lived experience role. But that is part of what makes the lived and living experience workforces so vital. We hold real-time insight into what's changing, what's working, and where the gaps remain. One of those gaps struck close to home. While my daughter had the incredible opportunity to have a peer worker walk alongside her, my son, her older brother, did not. He too was experiencing suicidality last year and engaged with services. This wasn't because he didn't want or wouldn't have benefited from peer support. It was because there wasn't another consumer peer worker available. We know peer support works. The issue isn't effectiveness, it's access. And access isn't just about hiring more people. It's about rethinking how we structure our multidisciplinary teams. If we're serious about embedding lived experience leadership in healthcare efforts to support people in suicidal distress, we need to move beyond one or two part-time peer roles within large clinical teams. We need to ask, do our staffing profiles reflect a genuine commitment? Or are we still treating lived and living experience roles as an optional extra? If zero suicide is about transformation, then our teams must reflect that transformation. And if we truly believe in the power of lived experience to drive change, we must fund it, embed it, and scale it up, not just in principle, but in practice. Supporting people in suicidal distress, including their families and natural supports, requires more than clinical interventions. It's about how we see, hear, and connect with people in moments of deep distress and adversity. This work is relational, systemic, and deeply human. It reflects the quality of our relationships, the values that we hold, and the culture that we create. If we want real change, we need to invest in the workforce that understands this, not just in theory, but in their bones, because we live it. So that's it from me now, but I'm going to hand over to Nicholas Proctor.
Thank you so much, Sarah. And what a powerful beginning to the session. What a powerful way to make some really strong points about the value and contribution of lived and living experience in our healthcare system. I'm going to talk about this in a slightly complementary way, but also add to some of the important points that you've made by talking about some research. And one of the groups that we've been quite interested in and concerned for in recent times are people who are recipients of the NDIS. So people who are attending the emergency department who have a psychosocial disability and an NDIS plan in suicidal crisis, in mental health crisis. And we've been talking to people about that and their experience, as well as service providers across different disciplines. But I just want to zero in on this important work led by first author Heather McIntyre and a whole group of people who have joined with her to really talk about these experiences presenting to the ED when mental health care needs or suicide-related distress type needs had increased beyond what the NDIS support could cater for. And knowing that the boundaries of NDIS support and our interest was how could communication practices be improved between the two services, the emergency department and the NDIS. And we found that one of the main takeaways from this interaction was discontinuity in crisis communication pathways and discontinuity in supportive relationships. So what I'm saying here is that NDIS recipients in mental health and suicide-related crisis reported that the ED staff really didn't lean into a communication pathway between NDIS supports and what could be provided or supported to people within the emergency department context. The descriptions coming through were it resulted in a pullback of intervention and a quick discharge and a return to normal supports. But at a deeper level of analysis, what we found was it created an information deficit, leaving people being returned to the drivers and the situation closely linked to initially presenting to the ED, resulting in some participants of our particular study being very hesitant to return to the emergency department in the future. And if they were to return to the emergency department in the future, they wouldn't declare their NDIS plans. And here's this quote from one of the participants that we spoke to, and I'll read that out. I just feel like it would have been good if there was some open communication between the ED and support worker coordinator, because some of the people would represent on numerous occasions and be turned away, and having that, oh, you're actually not coping at that moment because you're presented this amount of times. And what we can do to put support in place, just having feedback from the ED to them would be really helpful. So the opportunity lost is an opportunity of person-centered, strength-based services being stepped up rather than pulled back. And the reason why this is important is that we're also seeing a parallel concern. It is a national concern, but also a global concern around the attitudes towards people who do seek support at times of self-harm or attempted suicide in the emergency context. So this is a review paper that was published about 24 months ago, and it was published in response to increased levels of self-harm, which are substantially increasing in recent decades. And this review paper really wanted to know what the experiences were of people in crisis, particularly in emergency contexts, not just in the emergency department context, but also in the emergency context for the NGO sector. And the results are not good. The findings point to a re-traumatization of people who experience suicidal suffering. So this review found that people who present to services after self-harm, they tend to have more positive attitudes towards non-clinical NGO humanistic approaches, providing therapeutic contact rather than emergency departments and inpatient units. And what's concerning here is that the review's findings suggested there'd been little change in the generally negative attitudes and experiences of people who self-harm since a previous systematic review that was undertaken some 16 years ago. And here's the thing. Most people trying to access help for self-harm experience stigmatizing attitudes from professionals, minimization of their distress, superficial or rushed psychological and social assessments, but a range of organizational barriers, such as long wait times and limited access to care. So this research evidence really echoes the very important points that Sarah made in her opening statement. This is such a concern because we know that people do hold back from seeking support in a suicide self-harm crisis. Here we have evidence for NDIS recipients holding back, and here we have global evidence for people who also will hold back and be reluctant to disclose. And there's a whole range of reasons why that can happen. And I'm just going to zero in on two and progress the discussion. The two I'm zeroing in on are invalidation, stigma, including self-stigma and social stigma, but importantly, a pessimism about outcomes from help, including harmful practices. And this is important in safety planning, to be able to have a conversation with people to make plans for future safety. I think of safety planning as making plans for future safety. And one of the key things is to have an authentic, attuned conversation with somebody about reasons for living. And the idea here is that when people identify reasons for living, even in the most excruciating or unendurable and insurmountable contexts, when people identify reasons for living, they're less likely to take action that threaten those reasons. So a personal safety planning conversation should really begin by helping a person identify reasons for living, encouraging hope for this future, and establishing a rationale for the plan. So what's helped you get through difficult times in the past when everything else seems hopeless? When life is unendurable, what keeps you going? And what we know is the context, the worker, the culture, and the way of working is really going to be able to shape those sorts of conversations, or should shape those sorts of conversations. We've looked very closely at safety planning. We've found it to be very effective, particularly for people who are who have a history of trauma, significant trauma. Those interventions are best delivered in person, side by side, and the primary measures for what we found were improvements in suicide-related outcomes in particular. More recently, we had a look at the perspective of safety planning from both clinicians and people with lived experience. And the main takeaways, the most significant takeaways for consumers, clinicians, and support persons involved in safety planning is the beneficial way in which collaborative, authentic, compassionate engagement, listening to listen rather than listening to respond, emphasizing the importance again of collaboration, was so powerfully strong. But as Sarah said in her opening statement, it shouldn't just come down to the worker. It shouldn't just be who's on that particular shift. It shouldn't be the one or two people who seem to stand out. It needs to be everybody. And the benefits of safety planning, the lived experience, knowledge, and wisdom technique that comes from safety planning. Here's a quote from one of the participants that we surveyed, the data that we examined, and I'll read that out. At least somebody helping me. It makes me feel that as if somebody cares about me, like I'm not alone in this situation. This is a comment about having a safety a support person at the time of safety planning. It shouldn't really be that come down to one worker. It needs to be much more systematized and organized. And this brings us to a really important piece of work originating from South Australia, published last year, which is about transformative systems change. So, what are the pathways for strengthening lived experience leadership for transformative systems change that we can go to? So, this is data from 182 people across South Australia, generating knowledge and community action and research knowledge. This is coming together of lived and learned experience. It's a multidisciplinary, if you like, an intersectional group of people, really skillfully led by a lived experience academic, Mark Lockhead at the University of South Australia, published in Health Expectations, dialing in, if you like, on the actions for systems change. Specifically, how do we define, value, and embed lived experience leadership at an organizational level? And the arguments for shifts and why they're needed are compelling. It begins with a foundational understanding of shared guidance coming together, transforming suicide prevention, sector-wide systems, experience, and outcomes. So this is a group of 182 people from across South Australia who identified with lived experience, identify as sector leaders and project advisors who can speak openly and in a forthright way about lived experience leadership. So one of the models that's published in that paper, the Health Expectations paper, is up on the screen right now. This is a model for visioning suicide prevention systems transformation. And you can see a whole range of really, I think, virtues and attributes, nurturing connected collective spaces, centering lived experience, leading with change, knowing how and when to move in new ways, and sharing power really with people who also exist in the suicide prevention ecosystem. But as I said, it shouldn't just come down to the worker on the shift that day. It must also include and embrace people in senior leadership roles who can really orientate this thinking at a more practical and operational level. And in the next slide, I'm identifying leadership actions. These are again published in the Health Expectation paper, really to summarize these actions for mental health and suicide prevention systems transformation. So we're really talking about senior level cultural change, root and branch reform around lived experience leadership, advocacy, professional development, and formal qualifications for pathways for leadership skills and development. We're really talking about proper funding for lived experience organisations. We're really talking about meaningful resource flows for co-production of all suicide prevention services and programs. And importantly, ensuring that suicide prevention frameworks and models of care include recognition, equal recognition of lived experience workforces and peer support. It really does require a substantial rethinking, knowing how and when to move in new ways for the effective recognition and valuing and embedding of the lived experience workforce. So that's my message today. We've got really clear anecdotal storytelling, profound storytelling of the experiences of people, but we also have research evidence that points to the significance, the urgency, and the priority setting around learning and cultural change programs built around bringing lived experience into the room, and having a meaningful way in which executive leaders, staff, and communities can really benefit from that at the point of care. And finally, just a few of the people who I work with, who travel with me, who've helped shape some of this thinking. And Heather McIntyre, one of the authors that you have just been introduced to in today's presentation, is just standing beside me there. So thank you very much, everyone. Thank you for your attention.
Well, thank you, Sarah and Nick. That was amazing. Very powerful messages on the need for change and transformation in leadership and our mental health. I'll just go to some questions. Let's have a quick look. There is one question here. Question for Nick. With ED being so busy, it's difficult to engage with zero suicide implementation. What can we do to effectively engage with them?
Yeah, that's a great question. And I happen to have a small project with emergency department nurses right now where these are the questions that come up. And it is about incrementally leaning in and bringing compassion in those interactions. It is busy. There's no question about that. But it's also the human self and the positioning of the self in that busyness, and supporting people to look at the power of that, the value of that, not just in the present moment, but look at the future value, and bringing people around to recognizing present and future value of those compassionate actions that we all have within us in that context. No, there's not a lot of time, but yes, there's a lot of opportunity for compassionate action.
Thanks, Nick. That's great. Sarah?
Can I just add briefly to that? I think that's a great point, Nick. We've just opened a new mental health AOD hub at our hospital ED. And one of the things that we're finding is really, really important is actually to support nursing staff to feel more confident in stepping into the space around mental distress. It is work that they are already doing, but it's often seen as the purview of only mental health clinicians or mental health nurses. So it's actually, I guess, organisations stepping up and providing that support around why language is so important, and looking at their education needs about why this is so integral to everything they do, because let's face it, most people coming to hospital are experiencing some kind of distress. The other thing is actually getting peer workers into EDs. That's making a big difference. We're only at the very early stages of doing that, but we know that other EDs have done that really successfully.
Yeah, that's great. Thanks, Sarah. One last key message, guys. So, message to leadership that are out there listening at the moment. What is the one thing that you want to take them to, for them to take away from your presentations today? A message to the leadership out there. You've provided many already. One on the spot. If you could choose one, what was the biggest thing?
I guess lean into it. Lean into this space. It can be uncomfortable work because it involves recognizing that in our efforts to help people, we are often causing harm, and that short-term gain around stabilization is not necessarily and often is not leading to positive outcomes. So it's okay to power share with us. We're there to support you. We're not there as lived experience leaders to work against you. We want the same outcomes. It's just about getting around the table together and having those courageous conversations.
Thanks, Sarah.
And for me, I'm really clear about this. Know who you are, what you stand for, and how you work with others. Leadership is about followership, creating followership. That's true, but also allow yourself to follow. So in other words, look to those people with lived experience, wisdom, technique, and knowledges, and follow them on their journey as well.
Brilliant. Thank you so much, Sarah and Nick. If you have any other messages, I'm sure we can take them on notice as well, and we'll forward them on to Nick and Sarah in due time. So thanks again, guys. Absolutely brilliant. Really, really appreciate it. Thank you.
Thank you.
So I have the awkward situation of introducing myself to the next presenting presenter. Why am I doing this? This is literally a clinician's view on a case for change. And hopefully it's provocative, and it really kind of focuses on what clinicians face on a daily basis, particularly in emergency departments, and the complexities from a systems, organizational and clinical practice change. And I have to share my screen. I've just been reminded there. So let me do that now. Okay. Okay, so some of the complexities faced by clinicians working with suicide risk. Oh, okay, 1 second. Okay. Oh, my PowerPoint is gone. 1 second. Can you see that? Okay, still not getting my PowerPoint. I'm going to have to go with your PowerPoint. I can't come on it. Okay, so case for change. This is the snippet of information that are used when helping and assisting services around Queensland and AU in regards to having a case for change for why we need to have system and suicide prevention, in particular reform within our health services. Can you change screen? So today I'm quickly going to focus on identifying suicide risk, some of the challenges with that, risk categorization, and suicide and the impact on clinicians. And these are certainly barriers to the suicide care that clinicians are trying to provide. I think this kind of sums it up a little bit. It says healthcare is filled with a lot of moral injury because you're constantly failing. You want to help people and the system isn't built to do that. Which is an interesting statement. Let's go to the next slide. So identifying suicide risk. In mental health services, we've often used diagnosis as a gateway to treatment, and yet many people, in fact most people who die by suicide and who present to our service post-suicide attempt do not necessarily have a serious mental illness or an Access 1 diagnosis. Our clinical processes are engineered around the idea that we can predict risk, and our job was to find the mental illness and treat that. So traditionally, there's been a strong focus on assessment as an end in itself, rather than the provision of follow-up and crisis intervention. In fact, all the training, or most of the training that's offered, focused wholly on assessment and categorization, with little or no training offered in what essentially to do next, or interventions or pathways of care. Next slide. So some of the challenges when it comes to identifying suicide risks. Many people minimize their suicidality, and many people see no hope or relief from their suffering, so have little incentive to want to relay suicidal ideation to clinicians, and people may be quite cautious about revealing the full truth, as for the greater part, they may still want to die. They may share some of their suicidal ideation, some of their actions or plans, whilst hiding their real intent or method of choice. Next slide. So why are patients experiencing suicidal intent being hesitant to openly share information? I think you will need to click. So let's have a look. So the impulsive patient may lack extensive suicidal ideation before his or her attempt. People may be perhaps withholding their method of choice because they don't want to be thwarted. They may see suicide as a sign of weakness. They may be ashamed to acknowledge it. It may be immoral or a sin in their religion. The discussion of suicide is literally taboo. They may be worried the clinician will perceive them as crazy and lock them up in a mental health ward. But overarchingly, the patient doesn't believe that anyone can help them. Next slide. Very slow transition. So it's sometimes easy to believe that if we ask directly about suicide, the patient will answer directly and truthfully, but this doesn't seem to be the case. Next slide. From a psychodynamic perspective, there's a curious paradox that can arise. If a patient believes that suicide is a sign of weakness or a sin, unconscious defense mechanisms such as denial, repression, rationalization, or intellectualization may create the conscious belief that the patient's intent is much less than it actually is. So when asked directly about suicidal intent, this patient may provide a gross underestimate of their intent, even though they're genuinely trying to answer the question honestly. Next slide. From a phenomenologic perspective, some suicide patients relay their intent in stages. Whether evaluating such consumers in ED or a crisis line, one would expect that the consumer would share some information, literally see how the clinician responds or reacts to that information, and then share some more information and really evaluate where the session is going. Some consumers who are trying to decide how much to reveal may share details about a mild overdose, whilst consciously withholding their main method of choice, well aware that once they share that information, access to this method may be removed. And this may continue until they arrive at a decision during the interview that they do not want to die. And it's at this point they may feel safe enough to share the full truth with the clinician. Next slide. So we have to acknowledge that not all patients will openly communicate their suicidal intent when asked, even in cases where their life or death ambivalence has led them to present to our emergency department. Next slide. And the majority of people who die by suicide denied suicidal intent when last asked prior to their death, or communicated their intent in a more behavioral manner as opposed to verbal. Next slide. So we have to cease this normative approach to suicide risk assessment, which erroneously relies on an individual's communicated intent. If you just press the button there, there's another section under there. So we have to acknowledge that the clinical assumption, the absence of communicated intent, is synonymous with nil suicide risk, which is inherently flawed. Next slide. Let's look at risk categorization. Next slide. Last 50 years, there's been a major onus on clinicians to be able to predict future human behavior like suicide and assign people into categories of risk as being high, medium, or low risk of suicide. Our systems and processes and tools have been built around the expectation that as a clinician, we should and could accurately predict risk. And many clinicians over the years believe they've become quite skilled at rating suicide risk. And categorization of risk was often the focal point of acute assessments and language used to describe a person's suicide crisis. The belief being that categorization would identify most in need and those that could be managed in other community providers such as GPs. Press the button, please. We know that the data tells us that most people who die by suicide and are assessed by mental health services were categorized low risk just prior to their death. And we also know that risk factors and warning signs are actuarial in nature. They're based on broad population statistics and used to predict risk in an individual. But here's the thing. Next slide. There's a significant margin of error between assessing group and individual risk. And this margin of error as being so high as to render the risk estimates on individuals as being virtually useless. Next slide. The thing is, we would be right most of the time if we predicted low risk every time we assessed somebody, but not because it was an accurate prediction, but because, if you could just press the button, a vast majority of individuals who think about suicide will not attempt suicide, and even fewer will die by suicide. Next slide. The ratio of attempted suicide death by suicide is approximately 30 to 1. So there's a significant number of people who are seriously trying to end their life by suicide, but only a small comparative number actually do. And yet we've been asked as clinicians to predict whether a person will or will not go on to end their life based on actuarial risk factors, despite there being little or no empirically supported evidence that we can accurately predict future human behavior, especially suicide. Yet that is what we've been asked to do. That has been the major focus, and that has been the training. Weigh up the risk factors, weigh up the protective factors equals a level of care. Often our training is focused on assessment and categorization, not how to help, not how to intervene for a person in suicide crisis. And yet the evidence has been pointing the other way for the last 20 years. And a real lack of definitive guidance on how to help people through their crisis. Next slide. Psychiatrists in training typically learn that assessments of suicide risk should culminate in a probability judgment expressed as low, moderate, or high. The way of formulating risk has predominated in psychiatric education and practice, and despite little evidence for its validity, reliability, or utility. And add to this, little guidance exists on how clinical and actuarial-based knowledge should be integrated or what outcomes should be given to a particular assessment of risk. Next slide. So why are we excluding risk? Reasons that those who went on to die by suicide were rated low by clinicians. If you press the button. Well, a majority are categorized lower risk, so they make up more of the suicide, which is a bit of a paradox prevention. We become desensitized to risk as clinicians. We hear suicide multiple times a day in acute phases. Most people who come through the ED would be significantly at risk compared to the general population, but we become habituated and desensitized to this. There's a pressure often to label someone as low risk if the decision is to discharge them. And one view is that pressure arises because organizations and hospitals hope to protect themselves from criticism or legal action should an adverse outcome occur. But static statements of risk do not reflect the highly changeable nature of suicide risk. Next slide. So what we see is clinicians experience multiple false positives. And in the end, it has a major impact on them. They become quite defensive, quite pessimistic, even nihilistic sometimes. It was just a cry for help. It was inevitable. If they really wanted to do it, then they would. Or there's a sense of hopelessness within clinicians. There's nothing we can do. I don't know how to help this person. Or we see risk exclusion, denies suicide, no intent, no plan, or they weren't suicidal when I saw them, or suicide in the context of ETOH, or they're chronically suicidal. So the anxiety, fear, and trauma experienced by clinicians, particularly following the death of a consumer, cannot be underestimated. We may see an imbalance between the alarmist and dismissive positions which impact negatively on clinical care. And we often see unchecked countertransference, with the impact often resulting in traumatized staff focused on risk exclusion rather than identification. Next slide. We care so much that the emotive feelings of helplessness that can emerge when working with people with suicide risk can invoke those internal defenses to counteract those uncomfortable feelings. We can then subconsciously create defenses against those feelings and project these defenses as negative subjective statements. And I think most clinicians have heard these things before. It's just a cry for help. They were intoxicated. They're after secondary gain. They have some personality vulnerabilities. They're borderline or they're chronically suicidal. We want to help, but if we do not address culture and leave countertransference feelings unchecked, we risk minimizing the consumer's risk in care, and the use of language has the power to influence care. Next slide. And no more so than this next statement, which has discharged multiple people, if you press the button, from our services. Denies suicide, no intent, no plan. Now, everyone has used this, myself multiple times. Could you press the button, please? But here's the thing. It doesn't mean that they're not suicidal. And we know that most people minimize their suicidality and thoughts fluctuate and are often dynamic, because it doesn't mean they don't have a plan. We know that everyone who's suicide may not have a plan, but they certainly have thought about a method and how they would do it, not a plan. Exploring planning comes later, and it doesn't mean that they don't have intent, because we know that risk fluctuates, as does suicidal thoughts and motivations. So this statement really means we don't really know, and we have to stop using it to determine modality and levels of care or risk. Next slide. So removing the focus on categorization removes one of the key barriers for clinicians to be able to help people who present with suicide risk. Next slide. Let's have a look at suicide and the impacts that has on clinicians. Next slide. So major incidents and impacts on staff. So clinicians working in the complex world of mental health and suicide prevention, we face many challenges. One of these is the devastating impacts and loss of a consumer to suicide. And we work in a very, very complex system where complexities are not overtly acknowledged or reconciled within our responses to critical incidents such as suicide. And mental health workers have significant exposure to consumers who die by suicide. It's estimated on average that a mental health nurse working full-time experiences a consumer suicide every 2.5 years. Next slide. When a consumer dies by suicide, the death of a consumer frequently results in mental health staff experience a range of adverse outcomes. It really is one of the few topics that almost uniformly triggers anxiety and apprehension in clinicians, both novice students and seasoned practitioners. What we see is our staff experiencing physical symptoms that can include fatigue, insomnia, nausea. Psychological symptoms can include disappointment, self-blame, anger, guilt, shame, troubling memories, and anxiety. Next slide. So how do our services currently review those incidents? Well, they often see errors as markers of performance at individual team or system level, and they classify them as preventable or not. But we know that suicide is an extremely complex phenomenon, yet we continue to use linear processes to review such a complex event, which is often futile to find a cause and effect. There is much to be learned, often the result being little impact on risk and safety, and often an unrealistic expectation for staff and limited learnings from that particular process. Next slide. What we often see is workplaces with cultures of blame are often associated with negative patient and staff safety. We see places that are bureaucratic, where failures are considered isolated, systemic reforms are avoided, and new ideas are seen as problematic. Please click. Or pathological, where punishment and covering up of errors and failures are pervasive, and new ideas are often discouraged. Please click. The aim, of course, is higher reliability healthcare, where workplaces have recognized how safety can be improved and is rewarded. Next slide. So it's just a snippet of a broader piece of case for change information, and I will leave a link in some of the resources if you're interested in looking at this in more depth and more detail. Just a couple of messages for leadership out there. Reform can be overwhelming for many, and I have found that the Zero Suicide Framework and restorative justice learning culture approaches really do help structure and scaffold a reform process. We need managers to become leaders, and we need leaders to have vision and drive and motivation, and a lesser focus on maintaining the status quo. There are some amazing and dedicated and compassionate nurses, doctors, and allied health workers across Australia and New Zealand doing all they can within systems that have many barriers preventing them from doing the job that they signed up to do. Suicide is an emotive subject, and reform requires support and compassion towards staff, taking on Nick's comments, who have essentially been doing what they've been asked to do for many years. But we need leaders who are brave enough to take a hard look, a critical look at systems, processes, and clinical practice, and to articulate what needs to change, and then, most importantly, have the courage to do something about it. Thank you very much. So now, I wonder if we have any questions. If not, that's all cool. Hey, we have no questions for that. So we will move on to the next session. So it's my absolute pleasure to introduce Brian Amadani and Sue Murray. Dr. Brian Amadani is a senior scientist and director of the Center for Health Policy and Health Services Research at the Henry Ford Health in the United States. He's one of the architects of the Zero Suicide Framework. After leading with Dr. Ed Kofi the changes at Henry Ford Health, which really led to the design of Zero Suicide Framework. Sue Murray is our managing director of the Zero Suicide Institute of Australasia and an advocate for improving the way health systems respond to suicidality. And they both leaders in the global movement for zero suicide healthcare. Please welcome Brian and Sue.
Yes, I can. Thank you. Okay. Thank you, everybody. It's great to be here. I am thrilled to be. Okay. How's that? Okay. Great. Okay. Thanks, everybody. It is really a pleasure to be here with you today. I hope you're all having a wonderful day. This is a really great opportunity. I am really excited to be here because, we're, of course, leading this international initiative called Zero Suicide International, and all of you are embracing a regional leadership alliance, the Trans-Tasman Zero Suicide Healthcare Alliance. So what I want to talk a little bit about is a little bit about the bigger picture, the global movement that's happening outside of your region, and to which you're a part of this already. Tell you a little bit about how all this started and then where we are today. So I'm Brian Amadani, and I'm at Henry Ford Health, and it's really great to be here along with Sue. So let me just start back, and I'm going to try and go for 7 minutes or so, and then pass it off to Sue for the next part here. But zero suicide actually started in 2001, a very, very long time ago, almost 25 years ago now. And it started at Henry Ford Health, which is in the United States in Detroit, Michigan. It was a time, if you might remember, this field of suicide prevention in healthcare settings is so new, because back then, 25 years ago, only 25 years ago, there was a realization or a belief that there was really nothing we could do about suicide in healthcare systems. We believed as a globe, as a world, that there was really nothing we could do, and that it was inevitable if somebody wanted to hurt themselves. But we took a risk. And there was an opportunity. It's an interesting story because the United States is one of the worst performing healthcare countries among higher income countries in the world, if you weren't aware of that. And there was a report from our Institute of Medicine back then that described why the U.S. healthcare system was so low, so ranked so lowly. And the reason is because the U.S. healthcare system was fragmented, and it had lots of gaps in care. So you can get the best care today, but it was fragmented. And so people weren't connected across the healthcare system like they are in maybe Australia or New Zealand. So there was an opportunity to design what it would look like to provide perfect care, or a utopian model of care for people with a wide range of diseases, and you could pick your disease. We applied for this opportunity to develop what was called originally perfect depression care for people with depression. Remember, at that time, suicide was thought to be a symptom of other diseases. It wasn't believed to be its own thing that you could treat. So we applied for this opportunity. We did not get funded. And the reason why they didn't tell us that we could move forward with the project is because we didn't have a perfect outcome. So all of our team members got together, and patients and providers and healthcare leaders and administrators all got together, and they tried to figure out what it would take to have a perfect outcome for people with depression. And it was a nurse who stood up and said, if we were providing perfect care, then no one would die by suicide. And that was the day that we developed the idea or the concept of zero suicide. We redeveloped our entire healthcare system. We restructured care pathways. We found all the evidence we could about suicide, and we implemented everything that we could to figure out how to prevent suicide in our healthcare system. And within 1 year, as you can see on the right hand of your screen, we dropped our suicide rate by 80%. We have sustained that rate now going on 25 years, and we have at Henry Ford the lowest suicide rate of any healthcare system in the United States that publicly reports their data. It is a remarkable accomplishment, although we continue to fight every day to save the next person. In 2009, we actually reached zero suicides. And what happened after that is there was a bunch of research that evolved, and some of it by us, some of it by others, out into the 2000s and the 2010s. And we continued to integrate all that into our healthcare system. We published our initial paper in JAMA in 2010, and there was all sorts of international interest and attention. News from all over the world. England and Ireland actually came to the United States, learned from us. They started implementing some different components in their local health care systems in the early 2010 decade. Also, the United States National Strategy on Suicide Prevention was kicked off in 2012, and zero suicide, the healthcare framework, was an integral goal within the United States National Strategy for Suicide Prevention in 2012. It is now still in the national strategy, just released last year in 2024. And the United States government started adopting some of these policies, and they started pushing out funds and resources to get some of this implemented in the United States. Healthcare systems started doing this in the United States. And we recently finished a 5-year study showing an evaluation of 10 million people across 10 years in different states across the United States. And we found that in each location, after implementing zero suicide rates dropped significantly. And those papers should be coming out pretty soon. And one of them is already out for primary care, showing that we made a big difference in reducing suicide attempts and deaths at healthcare systems across the country in the United States. What also was happening along this time is that the Zero Suicide International movement really started. And in 2014, Zero Suicide International kicked off with the very first Zero Suicide International Summit. And that included a few countries in England. And now we have more than 20 countries from around the world participating, including Australia and New Zealand. Zero Suicide International, as it is now, is led fully by Henry Ford Health in Detroit. Actually, we have over 25 countries. We continue to bring on new countries, in all parts of the world. In fact, we have members from every single continent in the world, except for Antarctica. So every single continent in the world, we have partners doing zero suicide. And Zero Suicide International is really a bigger picture. It's more than just a summit now. We really think about it as research, policy and advocacy, clinical care, implementation and quality improvement, education and training and partnerships, because we believe that working together around the country and around the world is how we can make real difference in suicide prevention. We now have regional alliances and partnerships in different parts of the world, including this one that you all are part of. We have a big one in Asia, which has has 9 countries. We also have others in North America and Europe and Oceanic region, which is you. We also have partners in Africa and South America. We have specific programs that are brand new, started in Nepal and Pakistan. Here's a couple examples of projects that are going on. We hosted a symposium in Nepal in 2022, kicked off a big program focused on developing implementation strategies in Nepal. And think about this, a lot of these countries are low and middle income countries without the same kinds of resources. And so we can't just do it in the same healthcare structure. We have to think about new ways of doing this kind of work. But consistent with the zero suicide model, everything has to be connected to healthcare. So we can do screening outside of healthcare and connect people into healthcare resources, or use community health workers, or use school nurses to do some of this work and connect it into bigger healthcare systems. And that's what they're doing in Nepal, or starting to do in Nepal, and have also done in Pakistan, where they're developing virtual care pathways and starting them right in the school districts. We also host and continue to host the Zero Suicide International Summit globally. The summit, we had the 5th one last summer in England and Liverpool again. We did actually have one in Australia several years ago. I believe it was 2018, so you can confirm that for me. And then we will be hosting another one in 2026. Next summer, or next fall in September of 2026, and I hope many of you will be able to come. We have not announced the location, but it is generally near where you all are living. So I will stop there and pass it over to Sue, and then happy to answer questions at the end.
So good morning, and thank you so much for joining us today. I hope that you're enjoying our early presentations. Look, I want to familiarise everyone first with the Zero Suicide Healthcare Framework. It's a continuous quality improvement approach that's designed to support health services respond to suicidality. So just a quick refresher for everyone who's online. Of course, we have the 7 elements which make up the framework. In Australia, as Matt has talked about, we've really tried to encourage health services to think about setting a restorative, just and learning culture as a foundation for the implementation of zero. That is not an easy thing to do, and nor is it a quick thing. So it's important that we don't expect change in the immediate. It will take time to build. We also know that we have the longer term impacts of reducing suicide and suicide attempts within healthcare settings. And I think it's important to recognise that the Zero framework is about the healthcare setting. It is a complement to those wider strategies which are occurring out in the wider community. We certainly need to build, and we recommend first thinking about building the organisational capability. That means we need leadership commitment. We need to have trained staff that's commensurate with their roles and responsibilities. And we have to have in place a monitoring process that does allow us to understand, are we delivering what we intended to deliver? And is that achieving the outcomes that we wanted to achieve? On the right-hand side of the framework, we have the pathway and elements and practice changes that deliver that person-centered safety and clinical improvements. So those who do present with suicidality and their support networks are well equipped for recovery. And then we have some 20 outcome statements, and these are designed to help us understand how we're going to achieve the full implementation of the framework. So this really presents you with a snapshot on a page that you can show to your organizational leadership what the Zero framework means and what you are aiming to achieve with its implementation. If we look at Australia, what we've seen over the last few years, probably nearly a decade now, it's probably back in about 2017 that Queensland began their implementation on a statewide basis, followed by New South Wales, South Australia, and Victoria, all focusing on implementing the Zero framework. And fortunately, we are now also seeing West Australia, the Northern Territory, and Tasmania looking at this approach. What this means is that our health systems have greater potential to have alignment both within and across jurisdictions. Things like a common language, standardized pathways, and well-trained and confident staff. And what that means is better care for the individuals who are presenting to our health services. We know that this will give those presenting to health services a better experience. Suicide is spoken about openly and it's treated directly rather than as a byproduct of a mental illness or mental ill health. And so too are those working in a zero suicide organisation having a better experience because of this foundation of a restorative, just and learning culture. Staff will be trained that's aligned with their roles and responsibilities, and that will give them both confidence and the competence to work alongside those people who present with suicidal behaviours. We do have a range of resources that are designed to help make the implementation of the Zero framework easier. Our colleagues at the US Zero Suicide Institute have a plethora of resources that are available free of charge and based on the best available international evidence. So yes, they may need some tweaking to suit our Australian health services, but essentially you can be confident that those resources are delivering on the international evidence. And then the Zero Suicide Institute of Australasia, the resources we produce are designed to complement those US resources by providing resources within an Australian context. We also, as Brian has just mentioned, have the Trans-Tasman Zero Suicide Healthcare Alliance. And I would really encourage all of you to join TISHA. We meet on a monthly basis for the sharing, learning, and the and also the sharing of resources. So it's an informal platform where you can ask the questions of those who are also trying to achieve the same outcome as you and improve the quality of the healthcare delivery. And then finally, of course, we have the National Suicide Prevention Strategy that has just been released. And I think it's very encouraging for us if you think about the elements of the Zero framework and how they might sit within the support component of the national strategy. So much of what we're already seeking to do with the framework will help us align with the National Suicide Prevention Strategy. And then I think if you look at the critical enablers, the elements of the framework in its entirety are also going to really support the rollout of the National Suicide Prevention Strategy, which has been agreed by both the Commonwealth and state governments. So we should see that the work that you are doing within your health services is already shifting you in the right direction for responding to the National Suicide Prevention Strategy. And I think, this is one of the very early comments that prompted the the development of the zero suicide framework. When you hear that people present to our health services and then say, I would never return to the emergency department again, that's an indictment on our health services. We want to change the narrative. We want people leaving our health services saying, I got exactly the help I needed and wanted, exactly when I needed and wanted it. I hope you'll enjoy the rest of the program, not forgetting that we have our second session next Tuesday. But now can I head back to my colleagues and take any further questions that might be remaining. Thanks very much, team. Yes, please. And there is a question for Matt too in the chat, in the presenter chat.
Yeah. So we had a question earlier from Corey. Thank you very much. It's just saying, I love the idea of lived experience workforce being involved in relational interactions and care provision. How would you consider management of scope of practice and governance considerations would occur when increasing lived experience peer workforce responsibilities and roles, particularly with safety planning? So thanks very much for the question. Look, scope of practice is critical. Lived experience workers don't lead or deliver clinical interventions. We complement that work, including safety planning. So in our service, safety planning remains a clinical responsibility. However, peer workers may attend a safety planning session to support the person or their family or kin. Our role is relational and supportive, not clinical. We might share personal insights or examples to make the process more relatable. And in terms of scope of practice, we actively monitor for peer drift. So this is when peer workers start adopting clinical functions, language, or ways of working. Peer drift is managed very well, so long as you keep a focus on it, through discipline-specific supervision, co-reflection, reflective practice, and ensuring that there is role clarity within the service or organisation. Now, we're really lucky in Victoria. We've just had the release of the Victorian lived and living experience workforce discipline frameworks, and they provide excellent guidance on peer roles and scope. So those frameworks going forward are going to be key for supporting safe, values-aligned expansion of lived experience roles within multidisciplinary organisations. And I would really encourage any of you to have a look at those because they really are fabulous pieces of work.
Sarah, can I just ask a question on that? Are they available via a website so everybody would be able to access those resources?
Yes, I can find them and share that to you in a moment.
And I can put them in the resource gallery
Absolutely.
for people to access afterwards. Thank you.
Absolutely.
Okay, it looks like there is a question for me here. So the question is, hello, I am very interested in how overseas developments and the resources developed in different languages could be accessed by other countries, such as Australia. We know it's an issue amongst international students here, including from Nepal. Very interested in community support beyond health. Statistically, so many people who die by suicide never interacted with mental health services. So yes, absolutely. I think the last part is completely accurate, and that's why, we're trying to build this out into the broader healthcare system, including in primary care and in emergency settings and hospitals. We actually find that about 75% of people who die by suicide in the United States touch primary care. So in the weeks and months before they die. And so we really are targeting doing a lot of work outwards. We also are developing models to create partnerships across communities between healthcare systems and other organizations, clearly recognizing that in order to do this work, healthcare systems have to be the core, but they also really, in countries, especially like Nepal, and some other countries that are low and middle income, they don't have the same resources. They may have 3 psychiatrists in the whole country. So if you want to try to do the kind of work that we're doing in Australia and the United States, you really have to go outside and reach people where they are. And that means starting to do screening and with other resources like community health workers, school nurses, and teachers, but then link those services right into the healthcare system. Super important. As far as different languages, absolutely, quite a few of the research sources that we use are actually available in lots of different languages. Screening tools are already available in several different languages. The screening tool, the 9th item of the PHQ-9, for example, is already translated into 100 languages. We also have translations available to a lot of different tools. So what we're trying to do is actually get better access to these kinds of tools. And so I think over the next year or so, you'll see some connections to our zerosuicide.org, zerosuicide.org, which is the Zero Suicide International website. We're going to have a lot more resources on there and be able to point you to that. But we have done quite a bit of translation, and so have other people in some of their research. They've already started testing, so that there are tools available, and many of them in a lot of different languages.
Okay, I think we've come to time for the end of the session there, and I would like to thank Brian and Sue for your wisdoms on the Zero Suicide International. Absolutely brilliant. Just one question before you go, because I'd lost contact with the actual group here. What support, Sue in particular, provided to organisations thinking and considering going into zero suicide or starting zero suicide?
So maybe, Brian, if I just start out with that. One of the things I think is important is ensuring that you build this case for change. And that can be difficult because a critical part of that is data. So ensuring that you have some understanding of what the current status of suicide within your drawing area might be. Something I think the PHNs can help with. And of course, we are increasingly getting registries on a state-by-state basis. So it is becoming easier to actually get some information about your own data. Certainly contacting Zia, which is myself, to just get some ideas, get some linkages into other health services who are further down the track. And then, of course, as I often remind people, the US website has a huge range of resources that are freely available to everyone. As I mentioned, yes, they do need a review for language, may not be exactly the way we might express things. There may be some US style of approach to the resource which may need some tweaking, but not a lot. But basically that can give you the foundations for actually planning for and implementing. I think one of the other things that I've witnessed as health services have come on board is that there is a great tendency for health services to actually dive straight into the pathway. And that's potentially because, it's where people's level of confidence lies, because you are healthcare workers and clinical pathways are not an uncommon thing for you. But also both Queensland, New South Wales, and now South Australia have all produced pathways that have increasingly built on one another in terms of their sophistication. And so there is support resource around for people to move into the pathway. The problem with that is I see that a lot of those capability building components are not being addressed simultaneously. or not being thought about as readily as they need to be. So really ensuring that your implementation team has an executive sponsor, that's critically important, and then that you bring in those who are going within your health service who are going to be able to help you design the training program, design your data questions, data collection, and get those capability elements also operating at the same time as you're thinking about how you develop the pathway. And joining TSHA is the way in which you can connect with your colleagues in other states who may have already done what you're now being challenged with and can therefore short circuit some of those challenges that you might find.
Brilliant. Thanks, Sue. And so contact details for the resources for Zero Suicide International and TSHA will be in the resources page for this particular forum. So good stuff. Thank you very much, guys. It's with time that we take a break. So thank you to all our presenters today from this morning's session. Amazing stuff. Please click back to timeline, I think it is, on the top left of your screen. And please return at 10:40, where we've got some great leadership talks about their experience of implementing zero suicide and significant change when it comes to suicide prevention in their health service. So we'll see you all then at 10:40. Cheers.